For the osteogenesis imperfecta, it's a genetic bone disorder. So it's a bone disorder. It's also called the brittle bone disease, caused by a variety of gene defects, most commonly COL1A1 and COL1A2. So A1 and A2. Most common form is autosomal dominant. There is a decrease in the production of otherwise normal type 1 collagen. So basically, it's just the normal type 1 collagen at a different rate, at a reduced rate of production. We may have altered triple helix formation, and the triple helix formation was this one. Okay, so we may have some alteration in this helix formation. Manifestations include multiple fractures and bone deformities. So makes sense because it's a brittle bone. Okay, it's not tough, it's not strong. So we have multiple fractures and bone deformities. As in A, there you go. That's A right here. So that's bone deformity right here. And in addition to and after minimal trauma, of course, like bone deformities after minimal trauma, just like during birth, like the baby can have bone deformities after is getting delivered, like by handling the baby and pushing the baby and everything. We could also have blue sclera, just like this one. There you go, this bluish discoloration of the sclera due to this translucent connective tissue over choroidal veins. So that's because we do have some translucent connective tissue over the choroid veins, Some forms have tooth abnormalities, okay, including opalescent teeth that wear easily due to lack of dentine. So the main problem is the lack of dentine that's causing them to wear easily, like they get deformed easily. It's this condition is also called dentinogenesis imperfecta, not like osteogenesis. Osteo is a bone, while dento is the teeth. So dentinogenesis imperfecta, conductive hearing loss as well. We could have conductive hearing loss. That's because we have abnormal ossicles in the inner ear. We know they're required for hearing, and we have a deformity in those, so we don't hear very well. Maybe confused with child abuse. Okay, because like I guess the baby has a lot of hits and a lot of trauma due to brittle bones, so it looks or sounds like a child abuse. Treat with bisphosphonate to reduce risk of fracture. Patients can't bite bones, so it could have multiple features. Eye could have blue sclera, teeth could have dental imperfections, in ear that leads to hearing loss. That's for osteogenesis imperfecta. Let's see what we have over here. We do have bone matrix comprised of inorganic and organic components. For the inorganic components, it's hydroxyapatite crystals, that's inorganic, hydroxyapatite crystals, while the organic is type 1 collagen, okay? Type 1 collagen, okay. Type 1 collagen serves to give flexibility to the bone. So the organic component is the one that is giving flexibility to the bone. And thus, osteogenesis imperfecta causes bone to be brittle and prone to fracture. Why? Because we are having a decreased rate of the reduction of normal type 1 collagen. And that's it for osteogenesis imperfecta. We have the Ehlers-Danlos syndrome. It's a faulty collagen synthesis causing hyperextensible skin. Faulty collagen synthesis. So there is a defect or a problem in the collagen synthesis that is causing this hyperextensible skin, just like this one. If you pull it, then it just goes out with your hand. It's hypermobile joints and tendency to bleed. That's easy bruising. So hyperextensible skin, hypermobile joints, and tendency to bleed. That's easy bruising. Multiple types, of course, like Ehlers-Danlos syndrome has multiple types. Inheritance and severity vary, so depending on each one of those types, it may different, like the mode of inheritance and the severity as well. Can be autosomal dominant or recessive. May be associated with joint dislocation, berry and aortic aneurysms, and organ rupture. So, few things over here. It could be dominant or recessive because the mode of inheritance is just not fixed. There are multiple types. Of course, depending on that, we do have different severities of the disease. We may have joint dislocation, berry, and aortic aneurysms, and organ rupture. Hypermobility type, that's the joint instability. If we do have a hypermobility type, it's the joint instability and it's the most common type. While the classic type, that's another one, that's the classic type, it's joint and skin symptoms. So either it's only joint instability, that's the hypermobility type, and is the most common one. And the other type is the joint and the skin symptoms, that's the classical type. So it's caused by mutations in type 4, type 5 collagen, and that is col 5A and col 5A2. So this time the problem is with the type 5 collagen, okay? And as an example, it's col 5A and col 5A2. Let's see what we had here. So in osteogenesis imperfecta, we had different genes, okay? That's col 1A2 and col 1A1. While in Halodanlus, it's a different type of collagen, so it's col 5A1 and col 5A2. We also have some other type, that's the vascular type, okay? And it causes fragile tissues, including vessels like aorta, or like some other tissues like muscles, organs that are prone to rupture, just like a gravid uterus. So again, it's a vascular type. It causes fragile tissues, just like the vessels. For example, the aorta and the muscles and the organs that are prone to rupture, just like a gravid, like big full uterus. Mutations this time, like the vascular type, has the problem with type 3 procollagen. So type 3 and it's a procollagen, not just like the final resulting collagen, it's the procollagen. An example for that is col3A1. So all of these like col things are related to collagen, so it's col collagen. It can be caused by procollagen peptidase deficiency. It can be caused by procollagen peptidase deficiency. So that, of course, because we have ASE at the end, then it's an enzyme. So we may have a deficiency with the procollagen peptidase enzyme, leading to the Ehlers-Danlos syndrome. And there we go. Let's see what we have over here. So. What is the defect in Ehlers-Danlos syndrome? It is deficient collagen synthesis where the procollagen formed in extracellular space cannot transform into tropocollagen due to deficient procollagen peptidase, which cleaves the terminal N-C terminus of the procollagen. That leads to hyper extensible skin, hypermobile joints, fragile tissues with easy bruising. It may be caused by deficiencies of lysyl hydroxylase enzyme. So basically, there is a deficiency of one of the nice enzymes over here. I'm not sure if its name is present, but basically it's called um, procollagen peptidase, okay? And it works over here. It causes the cleavage of procollagen at the C and N terminus. So this enzyme should remove this part and remove this part, like the sides of the procollagen, leading to the like brand new name, the brand new type, that is the tropocollagen. So that's the problem in Ehlers-Danlos syndrome. It's deficient in the collagen synthesis because the procollagen formed in the extracellular space that goes out into the extracellular space over here cannot be transformed into tropocollagen due to that deficiency of that enzyme, leading to the hyperextensible skin, hypermobile joints, and fragile tissues with easy bruising. It may be caused by deficiencies also like from other enzymes, just like the lysyl hydroxylase enzymes. It's a faulty either, well, the faulty or like the problematic collagen synthesis is either due to defective procollagen peptidase or lysyl oxidase or gene defects. So three possibilities over here. We have either defective procollagen peptidase, that's one enzyme. The other one these lysyl oxidase, that's the second enzyme, and then the third, it could be just a gene defect, okay? And we said that bleed, it may have tendency to bleed if it affects like the vessels, then it may cause hemathroses and wound healing problems. So hemathroses is just like blood within the synovial space, like within the joints. So that's hemathroses, and it may also cause wound healing problems. One more thing over here is that different synthesis of fibrillar collagen. So a case that we have is a 3 years old boy is brought to the physician by his parents because of concern about his ability to heal from injuries. He reports that he develops bruises and scars. They report that he develops bruises and scars with even mild trauma, particularly in comparison to their 5 years old daughter. He was born at 35 weeks gestation without complications. He has otherwise been healthy and has developed normally. Physical examination shows extensible skin, and the joints are freely mobile. There are thin atrophic scars on both knees. A photograph of his hand is shown, but we don't see it over here. Which of the following is the most likely cause of this patient's condition? So the problem is a defect in the synthesis of fibrillar collagen, that's Ehlers-Danlos syndrome. So it may present at age of 3 years old as well. When this is due to defective lysyl oxidase enzyme, is characterized by kyphoscoliosis and ocular fragility. So if we have the problem specifically with the lysyl oxidase enzyme, it is characterized by kyphoscoliosis and ocular fragility in addition to these symptoms. Biochemical analysis will show decreased hydroxine and collagen tissues. We do that biochemical analysis, we could see the decrease in the hydroxine and within the collagen tissues. And we know that the hydroxine is one of the basic components of collagen over here. So makes sense to see those. Finally, we have the Menkes disease. It's an X-linked recessive connective tissue disease. X-linked recessive connective tissue disease caused by impaired copper absorption and transport due to defective Menkes protein, that's the ATP7A, also called absent copper to memorize it, versus the ATP7B in Wilson disease. So we know that Menkes is kind of like the opposite of Wilson. In Wilson, like we are able to absorb the copper, but we cannot get rid of it, while in Menkes we cannot absorb the copper that we need. So it's, as we said, X-linked recessive connective tissue disease caused by impaired copper absorption and transport due to the Menkes protein, that is the ATP7A uh, protein. While if we were talking about Wilson, then the problem would be in the ATP7B. That's Wilson. That's the copper buildup because we cannot get rid of it. Leads to decreased activity of lysyl oxidase. This time we know which enzyme the culprit, like specifically this one is the lysyl oxidase. Copper is necessary cofactor. So we are unable to absorb copper, which means we don't have copper anymore. So we cannot help the lysyl oxidase. We cannot like help it work. That's why we have a decreased activity of the lysyl oxidase. That leads to defective collagen and defective collagen cross-linking. So the problem is with the cross-linking of collagen, and it results in brittle, kinky hair and growth and developmental delay, hypotonia, increased risk of cerebral aneurysms. So brittle, kinky hair, growth and developmental delay, hypotonia, and increased risk for cerebral aneurysms. Okay, let's see. CU-dependent enzymes include lysyl oxidase, that's the copper-dependent enzymes, and include the lysyl oxidase and cytoplasmine, tyrosinase, cytochrome C oxidase, and superoxide dismutase. So copper is an important component in helping or aiding these enzymes to work. So if it doesn't exist or we don't have enough, then these enzymes don't work. And these enzymes are lysyl oxidase, cytoplasmine, tyrosinase, cytochrome C oxidase, and superoxide dismutase. Okay, let's see if it says anything about the lysyl oxidase over here. Yeah, it does say that if we have a problem with the cross-linking, it would end up as Menkes disease. Okay, there you go. That's the lysyl oxidase over here. It's number 7 is the formation of cross-links stabilized by lysyl oxidase. So that's the defective enzyme in the Menkes. Why? Because it doesn't have any copper to help it work and do this cross-linking with these little linkers over here. So for the elastine, it's a stretchy protein with a skin within the skin, a stretchy protein. Nice. This is stretchy, so just not fixed. With a protein within the skin, lungs, large arteries, elastic ligaments, vocal cords, epiglottis, and ligament of lava, which does the work of connecting vertebrae together. Relaxed and stretched conformation. Okay, so it does have two conformations. It could be either relaxed or just stretched or pushed together, and that's how they connect the vertebrae to each other. So elastin is found in the skin, lung, large arteries, elastic ligaments, vocal cord, epiglottis, and ligament of lava, and also rich in non-hydroxylated proline. Non-hydroxylated proline, glycine, lysine residues. Okay, versus the hydroxylated residues of collagen. So elastin, that's what makes it different from collagen, okay? Because elastin is rich in non-hydroxylated proline, glycine, and lysine residues, while the collagen does have the hydroxylated residues. Okay, that would lead to tropoelastin with fibrillar scaffolding. So in this image over here, it doesn't talk anything about it's only about collagen. Okay, and we can see that we have hydroxyproline, hydroxylysine. So the residues most likely to be hydroxylized, while over here it's not non-hydroxylated proline like glycine and lysine, and it has the final end result is tropoelastin with fibrillar scaffolding, and in the collagen it was just collagen fiber, tropocollagen ending as collagen fiber, tropocollagen ending as collagen fiber. This time in the elastin we have tropoelastin ending with fibrillar scaffolding. Okay, cross-linking occurs extracellularly. Okay, makes sense, just like collagen. Cross-linking occurs extracellularly via lysyl oxidase as well, just the same enzyme, and it gives the elastins its elastic properties, its stretchy properties. Broken down by elastase makes sense. Every elastase or every ASE is an enzyme, and its elastase is an enzyme that's breaking down, which is normally inhibited by alpha 1 antitrypsin. So, alpha 1 antitrypsin inhibits the elastase. So, if we want to keep someone stretchy, we just give them alpha 1 antitrypsin to keep it stretchy. The alpha 1 antitrypsin deficiency results in unstopped elastic activity, which can cause COPD. So, if someone, like a kind of patient who doesn't have enough alpha 1 antitrypsin, so they cannot stop the elastase activity. So the elastase keep eating the elastin, and the patient loses a lot of his or her um, elastic capabilities, stretchy capabilities, so they end up having COPD, chronic obstructive pulmonary disease. If we take a look over here, this elastin has two capabilities of stretching and becoming like this, or just actually relaxing and becoming like this, or just stretching and becoming like this. Okay, so this is the stretch state, this is the relaxed state. And there, as we can see, there's a cross-linking between each one of those elastins. Single elastin molecule. So there you go. This is a single elastin molecule. There's another one, there's a third one, and there is the cross-linking. This is the stretched phase, this relaxed phase, as we said. Let's see what we have. We have the Marfan syndrome. Marfan syndrome is an autosomal dominant with variable expression, connective tissue disorder affecting skeleton, heart, eyes. It's an autosomal dominant, that's one, okay? With variable expression, connective tissue disorder, it's affecting the skeleton, the heart, and the eyes. Skeleton, heart, and eyes. It's FBN1 gene mutation. Marfan, so just memorization, Marfan is FBN1 gene mutation on chromosome 15. Okay, another F for Marfan. So it's FBN1, it's 15 chromosome 15, and results in fibrillin 1, defective fibrillin 1. So there's a problem with fibrillin 1. Marfan, FBN1, 15, and fibrillin 1. It's a glycoprotein that forms a sheath around elastin and sequesters tissue growth factor beta. So it's this fibrillin 1. It's a glycoprotein that is supposed to form a sheath around the elastin and sequesters the tissue growth factor beta. So the findings of this patient could be tall with long extremities. He's tall, he has long extremities and chest wall deformity, just like pectus carneum, that's the pig's chest, or pectus excavatum, that's the contrary, like the chest is diverted inwards, like over here. While the pigeon, the chest would look like this, would have an outward bulging. So that's the pigeon chest, or the pectus carneatum, while the other one is the pectus excavatum, and that is just going inside. The patient also could have hypermobile joints, long tapering fingers and toes, uh, arachnodactyly. Arachnodactyly. That's tapering fingers and toes. With cystic medial necrosis of the aorta, okay, that makes sense because that comes with the cardiovascular system a lot. Patients with elastin problems, or basically Marfan syndrome, may have elastic medial necrosis of the aorta, ending up as you know either dissection of the aorta, or like a problem with the wall of the aorta. So, of course, it may lead to aortic root aneurysm, rupture, or dissection. So either their aneurysm would rupture, or they may develop aneurysm, and it's most common cause of death in patients with Marfan syndrome. Okay, mitral valve prolapse, of course, plus increased risk of spontaneous pneumothorax, with increased risk of spontaneous pneumothorax because they're tall and everything. That's one. That's the Marfan syndrome. Well, let's see if we do have any other notes. Yeah, we're gonna do have some other notes. We also have some other problem. That's the homocystinuria. It's most commonly due to cystathionine. Cystathionine. Oh, cystathionine synthase deficiency. Cystathionine synthase deficiency. That's homocystinuria. It's most commonly due to cystathionine synthase deficiency, leading to homocysteine buildup. If we do have a problem with that enzyme, the cystathionine synthase, then we don't have homocysteine anymore. That's why it builds up. Presentation similar to Marfan syndrome with pectus deformity, tall stature, increased arm to height ratio, so the arms are longer than expected, the decreased upper to lower body segment ratio, arconodactyly, as we said, joint hyperelasticity, oh gosh, joint hyperlaxity, joint hyperlaxity, skin hyperelasticity, scoliosis, fair complexion versus Marfan syndrome. Okay, so we need to compare it with Marfan syndrome. Okay, so let's see what we had in Marfan syndrome. We had a connective tissue disorder affecting the skeleton, the heart, the eyes, okay? And the patient would come as a tall patient with long extremities and chest wall deformities, with hypermobile joints, long tapering fingers and toes. That's arconodactyly, and cystic medial necrosis that may end up as aneurysm rupture or dissection. While in homocystinuria, where a patient would come as having pectus deformity as well to the chest. They are also tall, but there's like different ratio. There's a specific ratio between the arm to the height. So there's long arms when we compare it to the height. We also have like short upper extremities when we compare them to the lower body segment. So there is decrease of the ratio between the upper and lower body segments. We also have arconodactyly. We also could have joint hyperlaxity, like not stiff, and the skin hyperelasticity. So the joints and the skin. Scoliosis as well, and fair complexion. They would look fair, not dark skin and everything, not like the Marfan syndrome. So, if we compare those two, Marfan syndrome and homocystinuria, while the inheritance in Marfan is autosomal dominant, in homocystinuria is autosomal recessive. And the intellect is normal, like the comprehension and um, like cognitive function of the Marfan syndrome is just normal, while in homocystinuria it may be decreased. Vascular complications, Marfan syndrome may end up aortic root dilatation, while homocystinuria ends up having thrombosis. Lens dislocation, it's an upward temporal Marfan fans out or downward nasal in homocystinuria. So that's the lens dislocation. That's how they look. Uh, it's upward or temporal more in the Marfan syndrome, while they are drawn downward or to the nasal septum. So the nose, that's the eye. Yeah. So the nasal septum in homocystinuria. Let's see. So elastin generally. Elastin differs from collagen in a number of ways. It's one and two. One, it's very few proline and lysine residues are hyperoxylated in elastin. So basically it's all of those, as we mentioned, non-hydroxylated. So we only have very few proline and lysine residues are hydroxylated. Second, elastin does not form a triple helix. It just does not do it the way that collagen does it. Okay, there is no triple helix. There you go. That's the triple helix. There is no triple helix in elastin. Collagen and elastin are both composed of a large number of non-polar amino acids. Okay. Triple helix formation is the basis of the collagen molecule. Elastin does not form the triple helix. Okay. Triple helix formation. Okay, that's the same. Let's see. Nothing. And elastin normally degraded by neutrophil released elastase. So how do we break down elastin? of course, as we said, by the elastase enzyme, but where does it come from? It comes from the neutrophils. So neutrophils released elastase, okay? Alpha 1 antitrypsin deficiency mainly at lower lobes. Elastin is very similar to collagen, but is not heavily hydroxylated. Secreted in extracellular space as tropoelastin bound to fibrillin scaffold. So it is produced to the extracellular space, just like the collagen, but it will be bound to fibrillin scaffold, not like freely like this one, just bound to the fibrillin scaffold. Lysyl oxidase needs copper, so help cross-linking by desmosine. The lysyl oxidase is also required for the cross-linking of this elastine. If we don't have it, then we are going to have a problem with the cross-linking of these elastine molecules. What is normal rule of fibrillin 1? It is a major component of microfibrils that form sheath around elastine. So let's see, does it say anything about fibrillin 1? Not really. Anyway, so the fibrillin 1 is a major component of the microfibrils. What microfibrils specifically? They're the microfibrils that form the sheath around the elastine. So over here, we could imagine there is a sheath surrounding this elastine and like each one of those elastines actually. And it's uh, made of fibrillin 1, okay? It acts as a scaffold for deposition of elastin extruded from CT cells. It presents in abundance in blood vessels, periosteum, zonular fibers of lens. Okay, so that's where we can find the fibrillin 1 in abundance in the blood vessels, periosteum, zonular fibers of lens. Talking about the Marfan syndrome, it is the one that is having defective fibrillin 1. Okay, as the fibrillin 1 is the major constituent of microfibrils of the extracellular matrix. Microfibrils form a sheath around elastine fibers. So each one of those fibers normally supposed to be surrounded by the microfibrils that they do contain fibrillin 1. Fibrillin in the extracellular space acts as a scaffold for deposition of elastin extruded from the connective tissue cells. Fibrillin is an extracellular glycoprotein. Okay, so far so good. So for the cystic medial degeneration or necrosis of the aorta, its myxomatous change, pathological weakening of connective tissue in the media of large arteries are found in cystic medial degeneration. Medial degeneration is characterized by the fragmentation of elastic tissues. That's called basket weave pattern, and separation of the elastic and fibromuscular components of the tunica media by small cleft-like spaces that become filled with amorphous extracellular matrix pooling of proteoglycan in the media. Lysyl oxidase is inhibited by beta amino propionitrile, a chemical found in certain kinds of sweet peas, can mimic Marfan syndrome. Ingestion of this component can cause a change in elasticity of the aorta that mimic the myxomatous degradation seen in patients with Marfan syndrome. So the lysyl oxidase that's required for the cross-linking normally, it may be inhibited by this material, like or by this chemical component that is found in certain kind of sweet peas. That's called the aminopropionitrile, and it could mimic or look like as a Marfan syndrome. Most common cause of death is aortic dissection. That's the second most common cause of death in heart failure due to mitral valve prolapse or aortic regurgitation. Dilatation of the ascending aorta is seen in 90% of patients and frequently leads to aortic rupture with or congestive heart failure. Patients also have high arched palates, crowded teeth, and narrow face. High arched palate, crowded teeth, and narrow face. That should be it for the last team.